Well, hello, everybody, and welcome to another episode of the Doctor Entrepreneur Podcast. I am here with Dr. Josh Luke, who is a number one best-selling author of Readmission Prevention Solutions Across the Provider Continuum. And we are really excited that you've joined us today, Josh, and want to get into a lot more of the healthcare trends, but wondering if you'd first give us a little glimpse into your personal life.
Sure, happy to do it. Thanks so much for having me on the show. I spent 10 years as a hospital CEO, and I was blessed to have the opportunity at a young age, at age 32. And I did that after spending about 5 to 10 years doing sports marketing. And that was actually my dream coming out of graduate school. I have two older brothers that were professional athletes, but I wasn't blessed in the same manner athletically as they were. So I still chose to pursue a career in sports marketing. And that was fun for a few years, but I had a realization actually on a private jet on the way back from New York with Mark McGwire right after he broke the home run record in 1998. I was doing some work with him and just said to my wife on that jet, I said, hey, this has been an amazing time, amazing year. I'm having a great time. My brother was playing for the Dodgers at the time as well. But I said to her, I said, hey, I just think I want to do something different, something that makes a difference with the social mission. I wasn't sure what that was at the time. But within the next year or so, my grandmother's disease process as she was aging before she passed away, bless her heart, and then just an opportunity that came up to work in a nursing home arose. So between those two things, it was just put on my heart to make a career change to healthcare. And I did that. And after a few years training to work and lead a nursing home, I was approached by a hospital chain to be their CEO. And so I spent the next 10 years or so doing that. So it's been a fun ride. And
you started as a CEO at 32 years old.
Yeah, it was a fun ride, a quick transition, and a lot of learning on the job. But we were successful. We accomplished the goals they asked us to at that young age. And after about 4 years at that first CEO job, I was recruited by the competitor to go across town to be the CEO at another hospital in the city of Anaheim. So I kind of surrounded Disneyland with emergency departments there for about 7 years as a CEO, and it was a really good start to my career in healthcare.
Wow, that is incredible. Do you mind in talking about your timeline of successes, walking us through a time when you failed in your career?
Sure.
Something that maybe we can take away from that experience.
Sure. I think in any successful leader's career, there's going to be a number of failures, and those failures, from what I hear from leaders that I look up to, are the best learning experiences of all. And I think when you're turning around hospitals, and I was known as a turnaround artist for safety net hospitals, I really have a passion for serving the neediest of the needy. And in my book, that is the seniors that are aging, that are ill, those with behavioral health diagnoses. I just have a special place in my heart for that psychiatric community and that aging community. And now that's really transitioned into a passion for serving those with Alzheimer's and dementia as well, which is partially because of my mom's disease process as she's impacted by Alzheimer's. But as I was turning around hospitals, there was lots of lessons to be learned. And a lot of those lessons are shared in both my books, both Readmission Prevention and Execute. A former hospital CEO tells all about what's wrong with American healthcare. And the reason I share those titles and those stories is because in order to best understand why American healthcare is so broken, you really need to hear some of those stories. You need to have a visual you can reflect back to say, hey, this makes sense to me now, why it's so difficult for a hospital to invoke cultural change when we transition to value-based care. And I think the best example of failures, and it's not just when I was a CEO, but it continues today when I'm hired to go help big health systems implement strategic changes to transformational value-based care, getting your case management department to better understand why things have changed. To these case managers in hospitals, they're hardworking, very talented, in most cases registered nurses who have a passion for serving the needs of their patients, have always been empowered to go to whatever length they could to find a safe placement for this patient, and also give the patient choice in that process. What I've seen happening, and it really hasn't changed much since really 1999, 2000, when I really started studying and working in healthcare, is
Okay.
these case managers and social workers have really been the self-proclaimed defenders of patient choice for their patients. But now the game's changed. We've changed the game. So the hospital and health system is now paying for a lot of post-acute care, either through penalties or through risk arrangements. And so it's important for those case managers to know, yes, that patient has a choice, but at the same time, we need to communicate and educate them on what the choices are, and that we partner as a hospital with a handful of skilled nursing facilities, which we haven't in the past, and that actually we recognize patients would prefer to go straight home and not go to a skilled nursing facility or to a long-term acute care or to an acute rehab. And that's a massive shift. And I had several failures as a CEO where I tried to implement cultural change through the discharge process with case managers. And they were massive failures because the case managers felt empowered to stick to their guns and say, we got to defend the patient choice. But the happy ending to that story is now I've worked with several health systems across the country and explained to them how difficult this can be, and that they need to put resources to it, and that everybody all the way to the top, including the CEO, needs to be in the room communicating to the case managers that this is a change that has to take place, and the persons who benefit the most are the patients. But it's about educating and communicating the patients more so than it is about changing policy.
Wow. So you're talking about working together a lot more with the patient and communicating that, but it seems like with hospitals and how large they are, that becomes a real challenge for a CEO.
Yeah, no doubt about that. One of the things that I see as I travel the country and speak and provide strategy to folks is scripting has really become the differentiator for health systems that are truly transforming to value-based care. And when I mean scripting, what I mean is a physician or a discharge planner or a case manager, when they say, Mr. Luke, your mom is ready for discharge. Here are the 7 needs she has. Here's how we think they can be best met. Traditionally, what has happened is the case manager hasn't always communicated, hey, that you have a right to go home because the doctor said patient really needs to go to a nursing home to be safe. Well, the federal government has come and said, hey, being safe isn't what the medical benefit is for. The medical benefit is for somebody who has a need and meets the criteria. And so we've had a lot of bad habits, and I take full responsibility as the CEO of the hospital who was pressuring and leaning on the case manager to get the patient out the door so we can maximize our reimbursement. I take full responsibility in saying, hey, the game has changed. We now must communicate to the patient that they do have the right to go home always, communicate the risks that might be inherent with that, but also communicate to them which of the needs they have their medical benefit covers, whether it's Medicare, Medicare Advantage, or a private insurer. That's really the transition that needs to take place. And most people would say, well, gosh, Josh, we should have always been doing that. And the answer to that is yes, we should have, but we were not. We were saying, oh, the patient has Medicare, let's send him to a skilled nursing facility. And as long as the physician scripted that way, and the case manager scripted that way, for the most part, patients have never felt empowered to question their physician when he or she says, I think you can be best cared for here. And we continue to prove that by saying, hey, we've had our best results. The physician saying, hey, we've had our best results by sending patients directly home. And believe it or not, with non-medical home care or private duty nursing, not even traditional home health. And that might require your family to have some resources. One of those resources might be money. But we're going to at least script and tell you that and allow you to say, hey, we would love that, but we don't have the means to pay for it, or we choose not to pay for it, before we step back and say, okay, well, in that case, we believe that your medical benefit, in this case Medicare, will cover a little bit of therapy for your mom when she gets home. But like every benefit, it's capped. You know, Medicare, a lot of people think, oh, it's Medicare's king because it's the federal government's policy. Well, how backwards is that thought process? Think of every other federal government benefit or entitlement that they hand out. It's usually a bare minimum. And for some reason, we've lost sight of the fact that as great as Medicare is to provide medical insurance for our seniors, it is a bare minimum in most cases. And people forget that when you do go to Medicare Advantage or a Kaiser Permanente or a private insurer, a PPO, or even an HMO, they have resources in place well beyond that what Medicare usually will extend.
Wow, you bring up a lot of really good points that are helping to encapsulate, I think, what you're calling it value-based care, right?
Yeah.
And will you unpack what that means for our listeners just a little bit more? So when you talk to people, what is the framework of value-based care?
Oh, great question, and great timing on that question too. And the great timing is for this reason. So I'm going to answer the kind of timing question before I get into value-based care versus fee-for-service.
Okay.
I don't think many of us thought about until election night when President Trump was elected. I don't think anybody had stopped and said, hey, while Obamacare, which is also known as the Affordable Care Act, included many components of value-based care. It was the first massive implementation of value-based care. Nobody stopped and thought for a second, what happens if Obamacare goes away? Because nobody was prepared for President Trump to win. What we realized very quickly was that value-based care can't go away because there is no money left in the Medicare fund. It's running out at an alarming rate. And what I always say to people, just to kind of get them to personalize this massive issue, is let's take it down to the micro level from the macro level. Remember when you were in college, or at that age where you go to college, and your checking account was empty. You could not go spend things that you didn't have means to spend on. Well, the federal government's checking account is empty. And what they've been saying for 10 years now is stop spending our money on things that we can't spend them on, such as I already mentioned, sending people to post-acute institutions unnecessarily because it covers our liability or it's safer. That's not why a medical benefit's there. A medical benefit is there for somebody who has a need, right? And so that's why timing is so critical for this question right now, is because value-based care is not going anywhere. And there's not one person on either side of the aisle, Democrat or Republican, that is advocating for that or pushing for that because they know it's not an option. Now that we know the timing piece, let's talk about what is value-based care. And again, in both of my books, we go into great detail for both the layman and the healthcare executive on what fee-for-service means. Fee-for-service means in healthcare, the reimbursement model of the past has been a doctor gets paid a fee for providing you a service. You go to his or her office, he bills the federal government $135 for spending 10 minutes with you. You go to the hospital bills the federal government or your insurer $3,000 or $4,000 for spending a few days with you. So that was called fee-for-service. The inherent problem with fee-for-service was that there were no checks and balances. There was no accountability whatsoever, and there was no criteria required to go to the doctor or for a doctor to admit you to a hospital or for a hospital when you show up in their emergency room to admit you to their hospital. And let me give you a good example of that. And this might be the most shocking thing that I say in the hour we spend together. But anybody who thinks when you go to the emergency department in the days of past that the doctor is there to assess you and see if you're sick and need care, well, you need to study the model, the capitalistic model of fee-for-service a little bit better. That doctor is being paid by me, the hospital CEO, to find a reason to justify you to the hospital so I can get paid and he or she can get paid. And I usually pause for impact here for a second because it's hard to swallow. But that's what capitalism and healthcare led to. When you call your doctor and say, I have a stomach ache, he or she's going to say, meet me at the emergency department because he or she gets paid more and it's more convenient for them because they're going to the hospital that day anyway. And when you get to the emergency department, the ED doctor, who's a different doctor in the emergency department, calls them and says, why did you tell this patient to come to the hospital? Well, he was complaining. So therefore, the emergency department doctor thinks you're sick. And therefore, the emergency department doctor, who's incentivized to admit the patient to the hospital, admits you whether or not there's a need or not. They'll order 10 tests, none of them of which were needed. And one of them will show that you might be a little bit out of the range of where you're supposed to be healthy. And so they'll use that to justify why they admitted you to the hospital. The federal government again stepped in and said, hey, enough is enough. No more unnecessary tests, criteria for admitting patients. In the days of doctors pounding their fist on the desk and saying, doggone it, I've known Josh since he was little Joshy crawling around on his knees. And something was wrong with him that day he came to the emergency department. The federal government for years said, okay, we'll pay you. And now they're saying, okay, good job taking care of the patient you've known for 40 years, but we're not going to pay you. So you and the hospital figure it out. And that probably was long overdue. And so what value-based care is simply a means to say, hey, our goal, instead of episode-based reimbursement, which is a way I describe fee-for-service, you wait till there's an episode of an illness. Our goal is to keep people well. And so you hear the term population health thrown around. Population health is really kind of a a layman's term for value-based care, because what it suggests is we want to keep you healthy at home and avoid the hospital. Last week, I spoke at an event with a bunch of hospital CEOs from all over the country, and a couple of the best CEOs in the country spoke before and after me. And there was a lot of tweeting going on that day of what we were each saying. And one of the tweets that I saw that got a lot of attention, which was a quote I made, which I've said for years, is this: in value-based care, anytime a patient goes to the hospital, the emergency room, 80% of the time that will be a sign of failure of the system. And I think that really hits home with people, because now we're measuring from a different set of glasses to say, well, let's think about that. What does that mean? That means healthcare is best delivered at home and outside the walls of an institution. And that's our new measuring stick, as opposed to how well did the hospital do. And let me give you a little more definition on what I mean by 80% of the time it's a failure. It means the patient either didn't call the doctor, or a patient wasn't aware that there's a 24-hour clinic, wasn't aware they have access to a navigator or a coach through their insurer that can help answer the most basic of questions. And what many of your readers know, but several probably don't, is oftentimes the most common causes of unnecessary hospital visits, particularly the emergency room, are the social determinants of healthcare. I did not have transportation to go to the store, therefore I was malnourished. Therefore my refrigerator's empty. I could not refill a prescription, one of the most common ones. Another common social determinant that people underestimate is the anxiety associated with the senior citizen who might live alone, or live alone for part of the day, being discharged home from the hospital or a nursing home and just saying, I'm scared.
Yeah.
And so whether it's in the first 5 hours or in the first 5 days, they call an ambulance, because that's what we were trained to do. And I just wrote an article on LinkedIn. I encourage all your listeners to look me up on LinkedIn and follow me. It's Josh Luke. My mom blessed me with 2 really short, easy names to spell. And I write often for LinkedIn's Healthcare Pulse about this issue. In my most recent article, talked a lot about the fact that whether it's Obamacare or Trump care, and even before Obamacare, the inherent challenge in our delivery model is this. Many underserved, low-income patients nationwide understand our healthcare delivery system better than the rest, and they understand that they can come into an emergency room anytime, 24/7, and get free care and have very little consequence to pay for it. That predated the Affordable Care Act. It continues today. It's because of a rule called EMTALA, the Emergency Medical Treatment and Active Labor Act, which dates back long before Obamacare, that says any American, any patient, not even American, on American soil can go into an emergency department, and if they have an emergency or if they're in active labor, the hospital is required to treat them, no questions asked. And the hospital is really not even allowed to ask you what your payer source or ability to pay is until after that treatment's been delivered. So that was, again, predated the ACA and still exists today, and there's really not been talk about it going away. Until we put in a means where there's access to free care in clinics, that will continue to be the reason that healthcare is unaffordable, because this free care is being afforded to those who best understand the system. Let me share one other, or maybe 2 other points about the Affordable Care Act, which you know, regardless of what happens with Trump care, because Trump care at this point is more of a political suggestion than it is an actual plan. And Trump care, you know, in the present time here in 2017, is more just, we're going to undo the ACA and we're going to undo the taxes. Yeah. That's really all we know, and probably all we'll know until 2018. But let me point out why the ACA wasn't what was really failing on its own in a few capacities. And I'm not here to be political. I always am bipartisan and try to write and speak down the middle to educate you on policy. But nobody's debating that there were some inherent failures in the ACA. And I pointed a couple of these out in my writings early in 2012. And it came from the perspective of a hospital CEO who ran low-income hospitals. And I'll share those with your listeners because they've proven to be very true. Number one, not every American wants insurance. And let me give you an example of that. I keep hearing that 19 million Americans are losing insurance if Trump care gets implemented and Obamacare goes away. My question, more importantly, is how many of those 19 million want insurance, and more importantly, not want it, are willing to pay for it? Because the people that came into my emergency room and accessed free care and said they couldn't pay for it, and then went into the dining room and, you know, whipped out a couple $100s to pay for sandwiches and whatever it might be for their family, When you told them in 2011 and 12, hey, great news, you now get mandated insurance, it's $350 a month, that person's running the other direction saying, I have no interest. And that was
Absolutely.
the inherent flaw as soon as this legislation was announced. And I'm a 45-year-old male, and I'm still young enough to remember that most of my friends that were male had no interest in healthcare or insurance or in paying for it until they got married, because as young men, we feel invincible. And that leads me to my second inherent flaw that I stated in 2012 about the ACA, which is most of my guy buddies would not pay for insurance because they have no interest. And therefore, the premise was that the under 40 healthy folks that contribute would pay for the seniors who are higher utilizers. That was a flawed methodology as well for the reasons I just pointed out. And I remember sharing a story with my dad who does taxes. He asked me about the ACA in 2012, and I shared those 2 points with him. And I said, Dad, let me ask you something. What's the penalty for these young guys that are in their 30s that are coming in annually to get their tax return done? You're doing the tax return. What is the penalty? And he said it's $195. And I said, gosh, that's not even 1 month. That's not even 1 month. And granted, it went up over the next 4 years. I think it was close to $600 last I heard. But that was laughable, right? You just laughed and everybody else laughed. And I said, Dad, so what that tells me is if I was a young man in my 30s or younger that was not married, my only discussion about healthcare benefits or about Obamacare in the entire year would take place with you, my tax preparer, in March saying, how much money am I getting back? And your response being, I need to withhold $195.
Right.
And you saying, no problem. How much am I getting back? That was the entire conversation of an invincible young man for the first 4 years of the ACA. Now, again, the penalties went up, and that conversation has changed slightly. And again, I'm not here to say Obamacare was bad or good, or that Trump care is bad or good. I am an instructor in the School of Public Policy at the University of Southern California. So that makes me a policy geek. I'm here to interpret pending legislation and policy on healthcare and help doctors, hospitals, and now really business owners and families better understand how healthcare is going to impact them so they can prepare for it. So I'm proud to be that guy. But at the same time, oftentimes people misinterpret my interpretation of policy as taking one side or the other. It's really hard to take a anti-Obamacare approach right now because we don't know what that looks like. So the Affordable Care Act, I'll just close that question with this. The Affordable Care Act, whether you like it or not, its legacy is very clear right now, and it's undebatable. It expanded access. Nobody will debate that. They will debate everything else about how it expanded access, who paid for it, was it necessary? That most recent article I wrote on LinkedIn, the title was Universal Access versus Mandatory Coverage. And the whole point of that article was, hey, the legacy of Obamacare is clear, it expanded access. But what I've observed as a Gen Xer who really grew up in the 80s is that Americans did not have an expectation that healthcare was an inherent right as an American in the 80s. But after 8 years of an entitlement, that percentage of Americans, whether Republican or Democrat, whether conservative or liberal, that needle has swayed because that's human nature, right? So after 10 years, 8, 9, 10 years of an entitlement where, and think about the millennials, all they've ever known is that healthcare is a right. So if you polled every American right now, not only are all the millennials going to say it should be a right, but there's a number of us that are Gen X or boomers who have probably said, yeah, now that I've lived with it for 10 years, it seems like it should be a right. Whether you're conservative or liberal, that needle has swung. And that was the whole point of my article is now that we've lived with it for almost a decade, there's a massive difference in how Americans as a whole perceive universal access versus mandatory coverage.
Great point. And I imagine that your book gets into a little bit of this as well. Help our readers understand kind of the purpose of scaling into readmission prevention solutions across the.
Yeah, so great question. So after 10 years as a hospital CEO and a vice president over post-acute services, that was really a new title. The Affordable Care Act forced hospitals who'd been the king of the hill in healthcare, all the money flowed through them, to learn and think about post-acute care, which means a nursing home, a home health-based service, an acute rehab if you had an injury, whether you're young or a senior. And so in 2012, in my role as a vice president of a health system in Southern California, I was asked to be in charge of readmission prevention, which was a brand new penalty that President Obama had included in the Affordable Care Act. As I started researching it, no one across the country had any data on it, or really what I noticed is any enthusiasm to discuss it with me. And that was really the first sign that, wow, this penalty that's included in the ACA is complete contradiction to how healthcare is reimbursed. So not only did nobody want to talk about it or know anything about it, but it was really punitive. It was difficult to understand. It was the great unknown. And so as I started to research it and speak about it, I quickly realized, wow, I'm becoming an expert because nobody else wants to be. And so by 2012 and 13, because I had the street cred, as the term the millennials use, as a hospital CEO, as a nursing home administrator by trade, as now a vice president over post-acute, which brought those two together, as somebody with a PhD, as somebody who taught at the time at Cal State Long Beach and before that at Cal State Fullerton and now at USC, I've got a tremendous amount of street cred because nobody could say, hey, that guy doesn't know what he's talking about, because I had a more well-rounded approach to address these issues than anybody else did. So I studied it. I was speaking at an event. I got approached by the top trade organization in healthcare for healthcare executives, the American College of Healthcare Executives. They said, wow, we heard you speak. We've been looking for somebody to write a book on readmission prevention because it's so new and the great unknown. Would you write that book? So I spent a year researching it, and I founded the National Readmission Prevention Collaborative. And selfishly, that collaborative was to get the word out on the internet. Back then, we still called it the World Wide Web because it was so new. Back then, I just wanted to say, hey, if you know anything about this, here's a website where you can post a case study or a write-up to help me write this book. And that collaborative took off so quickly, the book actually got delayed because there was so much interest in this new topic. And it's interesting because although I said nobody was an expert on it, there was such an interest in people learning more about it. And so within about a year of starting this process, I became one of the leaders nationally in talking about the specifics of readmission prevention. I found myself presenting with folks from the federal government, from CMS, from the Medicare Innovation Center, sharing a stage with them at times, and Dr. Eric Coleman, who is really the #1 doctor and researcher in the space, and is one of the few people that had actually been researching readmissions long before the ACA came around. And he and I have gotten to be good friends. We co-present often. We present at the same events because he really presents from a scientific and physician perspective, and I present from an operator's perspective, not just the hospital and health system, but also from the post-acute provider's perspective. Okay. And really, to answer your question, the long form here is after writing the readmission book, I learned so much about the struggles of care coordination, and I thought back to my days as a hospital CEO and a nursing home administrator. People seem to really gravitate, not just to my personal story, that it was my grandmother's disease process that gravitated me to healthcare. And then I had some success as a turnaround artist. That's my personal story, which many people it appealed to. But my professional story was, gosh, as a 32-year-old CEO, so much of this doesn't make sense to me. And as I ask questions, it still doesn't make sense why we ever came up with this model. But now that I know that hospitals never had any incentive to care about what happened after a patient was discharged, it makes sense. So I'm going to be a pioneer and champion this topic to teach hospitals how to coordinate with nursing homes, how to coordinate with home health, how to coordinate with physicians outside of the hospital, even though there's only a little incentive now. There used to be no incentive. Now the financial incentives are starting to go in that direction, but slowly. And as that evolved even further after a couple of years of being kind of a champion for coordinating care, that's about the time Execute, a former hospital CEO, Tells All came out. But I also found myself championing home-based care, and it's because by that point in time, I became a caretaker for my mom. My mom has stage 7 or 8 Alzheimer's disease. It's an awful situation. It's an awful disease. I'm an advocate everywhere I go for Alzheimer's disease. My wife and I founded a not-for-profit, and we raised money for Alzheimer's support.
Fantastic.
But what I learned is that every American would prefer to age and heal at home. And when I speak now, one of the first questions I ask the audience, and it's for impact, and you'll learn I use provocative terms and I find things that have impact just to draw people in. Here's the question I ask my audience. Raise your hand if you can't wait for the day that you personally get to be admitted to a convalescent home and you get to stay there for the rest of your life. And not one person will raise their hand. And it really, and when you do that in a room full of healthcare executives, they kind of look at me like, hey, where are you going with this? Because I'm not sure I like it. Well, I'm going to a place where if we weren't all poisoned by the fee-for-service era, and there's a term I'll use that I can't believe I haven't used in the last 40 minutes, but I'll use it now. The fee-for-service era was simple. Put a head in a bed and you get paid. Put a head in a bed and you get paid. But I just did ask for a show of hands, and 300 people, now one of them raised their hand and said they can't wait to go to a convalescent home. Now I'm going to make another side point here. I use the term convalescent home, which you don't hear much anymore, because as a nursing home administrator, you're trained to never use that term. You're trained to never say
heard that before.
Well, so you're with all due respect, and this is a compliment, you're a millennial. And I want to talk the next question. Let's talk about millennial culture, because I'm a huge proponent of us having to adopt to it. Millennials haven't heard that term, and I'm glad that you said that, because I'm going to share that moving forward with your permission. Yes. I've met some millennials in the healthcare space who have never heard the term convalescent home, which proves my point. I was trained, to never use that term, and not even to use the term nursing home. And here's why. Because every American has promised their mother and their grandmother that they would never send them to a convalescent home or a nursing home, which is why we now call it skilled care or rehab or express rehab. 15 years ago, at least in the state of California, where I'm from, the state wouldn't even allow you to put the word rehab in your name if you were at a convalescent home. So I use the term convalescent home for impact. It's awesome that my understanding is you're broadcasting from Utah right now. Is that correct? Okay,
that's right.
Utah is one of the national capitals for skilled nursing corporate headquarters. So the fact that you're a millennial in the state of Utah, where skilled nursing is as strong and good as it is anywhere in the country, to have never heard that term, it just really proves my point. We can't use terms like convalescent home and nursing home because Americans know what those terms mean and nobody wants to go there. So we use different terms like senior facility, express rehab, skilled rehab. And it's just a rest home. It's a play on words. Because what happens is when your mom or your dad or your grandparent is in the hospital and they say, hey, we'd like you to go tour these 3 or 4 facilities, you see the names of rehab this and skilled that, and you walk in there and you have this realization, wow, my mom just needs a week or 2 of rehab in order to go home, according to the doctor. Why are there all these really old people here who look like they live here, some of them who have aggressive dementia that look like they're not going anywhere? And I'll give you another point. And I think your readers are getting a taste of what they can expect to read and execute and on LinkedIn. Okay. When you go to 2 of those 3 facilities, they're only going to take you to the 2 or 3 cool spots of the facility. They're not taking you to the dementia unit. They will make sure you avoid all of those, quote, older, sicker patients. And I say that with great respect because I'm in this industry because I advocate for those patients. But I also, as a young nursing home administrator, trained my staff to tour a rectangular building to go 60% around the way this way and then stop and come back, because we don't want our potential patients seeing the older, sicker patients in the back. So, that's just quote unquote good business when you work in nursing homes, but it's also showcasing the finer points of your facility and avoiding those emotional, sometimes the wrong side of emotional sites that you see when all of a sudden you go, wait, but this is my mom and I was told it was rehab. This looks like a nursing home. Well, guess what? It is a nursing home. Yeah.
Yep. I've had family members who have been in the industry and have had to get out just because there were some of the systems and processes that are implemented were just really hard to be a part of for them. They really struggled with the type of care and so
it's conflict.
I just think though about what you've said about how much better it could be for people, to spend more time at home versus having to settle for, a retirement type of a facility or a rest home for a period of time. My wife, she has a goal. We're actually going to have a baby in our home this September, and that'll be a first. But bringing all of the conveniences of a hospital into a home, someplace that she's more comfortable and someplace that she can be more rested and not feel like she's got all this attention coming from all these different angles. But I wonder if you wouldn't mind just unpacking a little bit more about what you've said a few words that for me I didn't know what they meant exactly, but just unpacking a little bit more of your vision of how you see readmission in the next few years. Some of the things that you're trying to help CEOs with.
Yeah, a couple of things. So I swear to you, I'm not good at and I don't like promoting my book, but in Execute, for this reason, we actually have like a 4-page glossary of terms that help you, because sometimes I get lost in the terms that I think everybody understands in the industry. But let's talk about, look, I got a book about readmission prevention. I got a website about readmission prevention. I talk nationally regularly. I present on readmission prevention. But here's the well-kept secret. It's not about readmission prevention. It's about admission prevention. The model of the future is an insurance model. You think about Kaiser Permanente on the West Coast and back in Baltimore and DC, and I think now they're up in the Northwest. They're an insurance model. They own the insurance company, they own the physicians, and they own the hospital. At the end of the month, they don't say, hey, did the hospital make money? If they said that and it did, somebody would get fired. The point in an insurance company is at the beginning of the month, here's $1,000 to care for Josh's mom. If you don't spend the $1,000, congratulations, it's capitalism, you made some money. If you overspent the $1,000, too bad for you. You better hope next month that you manage the care better. That is really the epitome of the structure of value-based care. Is here's the allotted amount of money that we're going to give you, and you're now responsible for that person's care. That's called managed care. There's a chapter in Execute about managed care, and it says, hey, the accountable care organizations that are mandated by the Affordable Care Act are just another name for HMOs. But for Gen Xers and above, HMOs were a bad word in the 80s. So when they reintroduced value-based care, they couldn't call it an HMO because we all said, oh, that was a bad thing. So they renamed it Accountable Care Organization. They're a little bit better at it nowadays. But it's about saying at the beginning of the month, here's a check for $1,200 for every senior. You're responsible for caring for them. So pre-authorization, criteria, educating them, self-management, all those things become relevant. And that's value-based care. So readmission prevention is a little niche. And when I got a call from Modern Healthcare Magazine a few months back, and they said, Josh, we're going to announce the readmission penalties for hospitals for this year. Can you give me just one quote on what this one tactic hospitals should do to prevent readmissions? And I said, that's easy. They need to reprogram their emergency department. And it's for the reasons I shared with you earlier. These doctors have been incentivized to find a reason to justify admitting you. What we need to do is unincentivize them to say, look, we won't get paid unless you meet criteria to be admitted. It's a complete contradiction, correct? So that's why I say it's about admission prevention, because it's an insurance model now. And what the federal government is doing with the ACA is, instead of saying, hey, Blue Cross, here's $1,200 per senior per month to manage their care, they're saying, hey, CEO of Intermountain Healthcare, here's $1,200 a month to manage this patient. You partner with their insurer and the physicians, and if there's any money left at the end of the month, you guys split it. So they're forcing the hospital and health system to become the insurer. And the long-term impact of that could be, this is an aggressive statement that would take 15 to 20 years to happen, but it could be the elimination of the middleman insurer. But not a lot of health systems have taken that aggressive approach quite yet. But several have, and they see it as the end game. And if they don't, what they're doing is they're deferring the power figure, the authority position in the model to the insurer. And hospitals have always been that authority figure, and now they're really giving that up to the insurer. So that's a slippery slope for them that they're not used to. The challenge I see with health systems that just baffles me is why health systems aren't reaching out and saying, Josh and others that are experts in this area, teach me how to make money outside of the walls of my hospital. Quite frankly, they've never had to, because times have been good. But there's something in the hospital that we call core staffing. And what that means is there's a bare minimum of nurses and caretakers that you have to have there in order to keep the doors open and to meet your licensure requirements. What's happening is the hospitals and health systems eliminate staff, and they will eliminate staff. Because remember the basic premise of the Affordable Care Act, which almost everybody forgets because it's capitalism. We have to remove spending in dollars from this model because it's unsustainable. But we want to keep care not only at the same level, but improve it. It's like a double whammy, right? So with hospitals, they're going to see less patients. They're going to get less money per day for the patients. And so as that revenue dips, at what point does the revenue dip below the expense of core staffing? We're not there yet in most cases. Now, let me paraphrase that. If you get the newsletters I do every day via email, several hospitals are there. It's called filing for bankruptcy or saying we're going out of business. And it's simple.
Exactly.
It's business 101. Your revenue no longer exceeds your expenses. And because there's core staffing in hospitals, I'm waiting for health systems to call now and go, hey, I don't want to wait till we're even close to that. Can you teach me how to make money outside the hospital? And I don't care if it's opening a burger stand in the empty lot that you own on your hospital. Can you teach me how to make money outside of the health system, outside of the hospital? Because the new business model, the hospital is the biggest expense. It is the biggest expense in an insurance model. So we need the CEO needs to not be the CEO of the hospital. And one of my old anecdotes I used to say when I speak is I need the CEO to move his or her office out of the hospital and across the street to the medical office building, because until you do that, your employees still think the hospital is the center of the universe. It's actually the largest expense.
Huh. Interesting. And so you've talked a little bit about how you're helping to support healthcare providers and keeping more of the money and improving value-based care. Talk to us about how you can help the patients, help us as patients save a little bit more money in healthcare.
Two ways to answer that question. Number one, Forbes magazine, Forbes Books just contacted me about 2 months ago and asked me, can you write a book that will tell executives how their company can save money and how they can save money? And so I have a contract with Forbes to write 2 books, one on each. Okay. And so that's the exact reason, because I've been asking this question a lot, and you'll like this question. I say to the business owners, because the first book I'm writing is targeting these Fortune 500 companies, to say, hey, at what point is your company spending too much money on healthcare? When's the tipping point? Yeah. And what do you think they all answer that with? They all say the same thing. What do you think it is if you had to guess? If you owned your own business and I said to you, hey, when are we going to reach this tipping point on when you're spending too much on healthcare for your employees? If you had to guess, what would you say the answer is?
Oh, man.
Well, let me just not put you on the spot. They all say it already passed. And I respond with, well, it can't have already passed, because the definition of a tipping point is you stop the behavior, and you haven't, right? So why, as Americans, is that like the only thing as business owners and families that we're taking in the shorts and saying, hey, I got to do this. It's okay that they're raising my rates 15 to 20% a year. I will tell you, my family reached a tipping point in 2011 when I was between jobs, and I went to my wife and said, hey, babe, we can pay $1,200 a month for insurance, or we can roll the dice till I get a new job. My wife and I spent 9 months without health benefits because we reached our tipping point. Okay. Yeah. That is a tipping point. We said enough is enough, even with 3 kids in elementary and middle school. So the second part of the question I kind of teased for you earlier. What is happening right now, not just in America, but in healthcare and in industry, is the rest of us must adapt to millennial culture. We have to. I'm a huge fan of millennial culture. We must do it. And the reason is because it's so efficient. Millennials were raised with a computer in their hand at all times, a phone, a pad. They're used to immediate gratification. If your listeners haven't watched the Simon Sinek video on millennials on YouTube, they should. It's 10 minutes long. It's Simon Sinek, S-I-N-E-K. It's fabulous, and it changed my life, not just as a father, but as a professional. I watched it twice, brought my wife in. It really helped me understand my children, who aren't even millennials. They're Gen Zs or iGens, whatever the next generation is going to be called. But the point is, they still have those traits of they're used to immediate gratification. They struggle to build relationships. They struggle with communication skills. Right. But in healthcare, we've always been slow to adapt because we say, oh, grandma and grandpa won't use an iPad. Well, guess what? The technology is too good. The other technology is probably not even supported anymore. Either they're going to learn to do it through self-management, or the caretaker is going to learn, right? Right. So you look at all these examples of millennial culture, and what I love about millennial culture, what I love about millennial culture is millennials were raised not just with the PDA in their hand, but they were raised that healthcare means living healthy, exercising daily, not overcommitting to work life. And as Gen Xers, and particularly boomers and millennials, there's a great article that came out last month that I have in my slide presentation. Maureen Bosagino wrote it, and it basically talks about, it gives a story of a boomer sharing an office with a millennial in a hospital, and how you might as well have hung boxing gloves on the back of the door. The boomer literally said, "Hey, I've been here 40 years, very proud to get my 40-year pin next week." And the millennial is shaking her head, looking at him like he's crazy, going, "Man, I'm out of here in 18 months, man. Why would you spend 40 years in the same place?" And both of them swearing that they're right and that the other's crazy. And guess what? They both are right. And it takes the rest of us, meaning the Gen Xers, the boomers, the greatest generation, to step back and go, hey, that's the world as they see it. And guess what? That's what drives the world, is the demographic that's 18 to 34 is what drives Madison Avenue. It's what drives Hollywood. It's what drives decision making in business. And so we must adopt. And so healthcare is the perfect example of that. People are wearing the Fitbits because healthcare is about staying healthy, eating healthy. The Affordable Care Act included incentives for your employees to live healthier. And my next couple books that are coming out is Healthcare Bankrupting Your Business. What are you going to do about it? And the next one will be, Is Healthcare Bankrupting Your Family? What are you going to do about it? Are going to largely be tactics to save significant dollars, thank you, on how your family and your business are spending money.
Fantastic. Any idea when those will launch?
You can look for the first book targeting business executives and owners to be out in the fall through Forbes Books, and you can look for the one targeting families and individuals to come out probably in the fall of 2018, depending on how quickly I can get my ducks in a row. It could be as early as spring 2018, because Forbes is really excited for me to write these books, and I'm excited about them reaching out to me to do that. So
I suspect there will be additional articles along the way that you'll be posting on LinkedIn that people can get a snapshot of some of the things to come in those books. Yeah.
So thanks again for mentioning that. Josh Luke on LinkedIn. I would love for you to follow me on Twitter. I have a lot more fun with Twitter. You can see a little bit more of the personal side of me. It's Josh Luke, the number 4 health. So Josh Luke 4 health, active on Twitter as well. Also, if your company has an annual meeting or an annual sales meeting, an annual executive meeting, or if you're part of a trade organization, even if it has nothing to do with healthcare, please reach out to me on LinkedIn. I would love to be considered to come speak. And here's the cool thing. When I come speak at your company's event, I almost always try to include a free copy of Execute the Book for everybody who attends. So if your listeners are in a position to shoot an email to somebody within their company to say, hey, I heard this guy on the radio, I went to joshluke.org and drjoshluke.com. I saw all the cool places he's spoken in all over the world, and he's got a couple books out. Can you consider bringing him to speak at our event? I've spoken for architects. I've spoken for churches. I've spoken for hospital CEOs. I've spoken for sales folks. I've done it all, and I love to speak, and I always get great feedback. It's always 90% or above that he was a great speaker. Can you bring him back? Or I wish he could have spoken longer. And that's just really gratifying.
Fantastic. And kind of, a one sentence answer. Would you mind summing up both books once again?
Sure. And, I don't have the ability to sum anything up in one sentence, but I'll try my best. Readmission prevention. Both books are available on Amazon.com, of course. Readmission prevention solutions across the continuum was written for healthcare practitioners. If you work in a hospital, a nursing home, if you work or own a home health, a non-medical home care, a hospice, assisted living, board and care, adult daycare, anything in the care continuum, this book was written for you. It's very tactical. The only thing in the book that would require you to spend any money to implement readmission tactics is buying the book itself. Number 2, Execute, a former hospital CEO tells all about what's wrong with American healthcare. What every American needs to know is available on Amazon. I think it's $15 new or something like that, probably cheaper if it's used, but it's written for everyone. Housewife, business executive, and there's 2 parts. The first part is really exposing the underbelly of healthcare and how screwed up our system is, why it's so expensive, why it's always about follow the dollar. The second part is the part that I was most proud that people really loved, because it was helping you as a consumer, as a father, as a mother, as an individual, better understand healthcare, but giving you tactics on how to save money and get access to care, but most importantly, empowering you to question your doctor and your caretaker as to what the other alternatives are when he or she recommends something for you.
That is huge. That my wife and I are huge advocates of understanding what our options are and being as well educated as we can.
Well, Execute is about a 3-hour read. It's like a one-flight read. I tell people it's fun, it's entertaining. Readmission prevention is not quite as entertaining. It's a very tactical, trade-focused book. So I think just about any American could read Execute and say, it was funny and entertaining, as well as giving me a few tips on how to save money and get access to good doctors and hospitals.
Fantastic. Wanted to ask, I'm just curious with your success. I was thinking in particular back to when you were 32 as a CEO. What would you say is one personal habit that's contributed to the success you've seen in your life?
Great question. I think the power of listening and understanding your audience. And I have 2 degrees in communication. And one of the things I think that I learned coming out of those 2 communications programs as an undergrad and master's before I went on to get my PhD, is that it doesn't matter how you communicate, it matters how you're interpreted. And you learn as a nursing home administrator, as a hospital CEO, as a public speaker, understand your audience before you open your mouth, and your communication will be much more effective. And I think learning that lesson as a hospital CEO, and I'll tell you a really quick story that encapsulates that. When I was trained as a nursing home administrator, they made me work in every department of the nursing home: laundry department, maintenance. I became a certified nurse assistant, finance office, business department, but they made me work in the kitchen. I washed dishes for 2 weeks next to an immigrant who made minimum wage, which was less than $6 an hour at the time in the state of Nevada.
Wow.
And he couldn't for the life of him figure out why the guy in the suit all of a sudden had to wash dishes with him for 2 weeks. But what I learned in that process, 2 weeks in a totally cool guy, what I learned in that process is there was more of those 300 employees of the healthcare facility that could relate to him than would ever relate to the guy in the corner office or the gal in the corner office in the suit that was raised upper middle class, went to college, got a degree, and they will just never be able to relate to you like they can relate to that line level worker. And as soon as you learn that, you're going to be a much better communicator in healthcare.
Thank you. That was an extremely instructive point. I really appreciate that.
Cool.
A couple more questions, just out of curiosity. How many kids do you have? Did you say you had 3?
Yeah, I live in Southern California, born and raised in Orange County. And I have 2 boys and a girl. They'll all be in high school here in 2017. It's fun but frightening. They're all into different things, and I have an awesome wife. We've been together almost 20 years, so she's been very supportive of this transition out of healthcare leadership into pioneering care coordination and helping businesses and families learn how to make healthcare affordable again.
Fantastic. Question I have for you is kind of another timeline type of a question. Looking into the future, I suspect we'll all have a moment in time where we'll be able to share life truths with those that we love, and I wondered if you wouldn't mind just sharing three things that have become absolute truths for you.
Well, I think having a partner like my spouse that is not only my best friend, but also where we both make a commitment to always lift each other up and to never bring added anxiety in a world where there is anxiety at every corner. That's certainly the last thing you'd want from your partner. And that would be number 1. Number 2, in contrast to that, understanding that alone time is important for those who are seek creativity, seek wisdom in times of being alone, meditation, whatever it might be, or prayer. Whether you're praying or meditating or just do your best thinking in the shower or while you're driving alone, I think understanding the value of who you are and the importance of having alone time, if in fact that's when you can be at your best, is important. And again, I would just come back to being a good listener and listening first and understanding your audience, which I think go hand in hand. So to me, those are 3 kind of personal / professional pillars that I always fall back on. And if I had to say a 4th, it would be that I play as hard as I live, and not everybody's capable of that. But my wife and I love to travel. My kids love to travel. I hope to afford them an opportunity to do and see the things in life they want, but at the same time teach them they understand the hard work and that it requires hard work to achieve those things.
Fantastic. Well, we are so grateful that you've made time to be with us. You've been with us for an hour, have provided a lot of insight into how the healthcare industry has changed, things that are happening with the Affordable Care Act. Definitely provided some great advice. I wondered if you'd mind just giving us a little bit of parting advice, and then we'll close the show.
Sure. Whether you're reading Execute or Readmission Prevention, or my forthcoming book is Healthcare Bankrupting Your Family or Your Business, there's one inherent message that is really consistent in all of those. And that's, as an American, you always feel empowered to negotiate when you're shopping or buying or whatever it might be. But for some reason, we feel disempowered to do that in healthcare. Empower yourself to negotiate with your hospital, with your doctor, with your provider, but also empower yourself to ask questions of your doctor and ask what your options are, not just for you and your personal health with you and your wife, soon to have a child, but also for your aging parents. Ask what the options are. And most people don't feel empowered to do that. And when you feel empowered to ask what those options are, you'd be surprised how quickly they'll provide you some additional options.
Fantastic. Well, thanks again so much. I'll keep you on a little bit after we end the show, if you don't mind. And for those listeners, hopefully you've taken some notes, and we'll look forward to connecting again on another Dr. Entrepreneur podcast. Thank you so much.